Oh no, it wasn't supposed to start. I think you started. Okay, so we should
5:57.
Joe,
Might as
just
well.
put your stuff on mute and we'll just start in about 4 minutes. Okay, hey guys, because now we're abroad. Everybody should mute their line at the presenter.
Can anyone hear me?
Yes, everyone can hear you.
Okay.
So we are broadcasting, so we're just sitting on mute until we start.
Okay.
What's up, Robert?
Can you guys see the beginning of the PowerPoint on your screens?
Yeah, I see it.
Okay, so what people will have to do is they'll just have to say next slide when they want me to change slides, or I can change the presenter to someone else. So it doesn't have to be me, but whoever wants to do it, just let me know.
I want you to do it, Louise, because you be slamming that shift key so hard.
Yeah, I broke my shift button right before we did this. It's 5:02, so I think we should wait just a couple minutes because I think we're still waiting for Zach. And is Zach here? Oh. All right, well, let's wait a couple more minutes. Hey, you guys, thanks for being here. We'll get started in just a minute. Okay, Hiawatha,
Yes.
it's about, I guess it's about 5:04. We've got about 58 people here. We want to go ahead and get started soon. I was hoping is Zach Talbot here? I tried to call him. I guess we'll go ahead in just a few minutes.
Okay.
All right, we'll just go with that. We'll do what we have to do.
I want to thank everybody for their patience. We'll be starting in a few seconds. My name is Hiawatha Collins, and I will start out as the first part as your facilitator.
Hiawatha, you want to go ahead?
Yes, thank you very much. First and foremost, it took a global pandemic to get a take home. This is a very important topic, and it is a national topic, and we are so glad to have our speakers and to have you, the rest of you, join us today on this topic. We have guest speakers that will be speaking on this said topic. This is presented by the Urban Survivors Union and NIAM, the National Academy of Medical Assisted Treatment and Urban Survivors Union. One thing we want to say is that this is very important. This is a very important topic. You have the opportunity to ask questions in the chat box. We may not get to all of the questions, but we will try to answer all of the questions. Those that we do not get to, keep in mind that we will try to answer them the best of our abilities, but we will respond to those later on through email. I am Hiawatha Collins. I am the facilitator for this. I work for the Harm Reduction Coalition, and I'm a part of Vocal New York Users Union, and I'm a part of the Urban National Survivors Union. Every speaker will have 10 minutes to speak. I will be the moderator of the timekeeper and the moderator of that, so please try to keep your comments to 10 minutes so that way we can get through this in a timely manner. One thing that I want to say is on this topic, we want to make sure that we do not go back to business as usual after this is over. We have fought so hard, fought so long for so many changes that did not come about. So some of the changes that did come about, we want to make sure that we keep those in place, and you're going to hear different views on that today and why it's so important. We have guest speakers coming up, and the first one right now will be Ms. Louise Benson.
Hello, my name is Louise Vincent, and I am with the Urban Survivors Union. Yes, so we have a new leadership team in Urban Survivors Union. We're moving away from a one-dimensional hierarchy, and so we have a number of people on our leadership team. So you'll see today we have a number of people from our leadership team here talking about methadone. What's so cool about this is we are having a real say in our health. This is people on methadone, people who use drugs, having a say about what happens to them in their lives. I feel so grateful to be a part of this. I'm not going to take up too much time because we have so many important people to listen to today, and I'm just really grateful to be here.
One thing that I want to add real quick is the one reason why this is so important, and the real important part of this is also the fact that this is predominantly everybody on here is affiliated with the methadone or buprenorphine program in one way or another. So this particular webinar nationally has been so long in the coming, so long it needed something like this to be. And as Louise just stated, it is something that was done by those same individuals so that they can have a voice. So this is your opportunity to also have a voice and to ask questions and to add on to the conversation. So please be a part of the conversation, and let's hopefully we can all come together and do something real constructive around this particular issue.
Is Zach here? Zach Talbot?
No, I don't see him. I don't see him on.
Okay. Well, Zach Talbot from the National Association of Medication Assisted Treatment is supposed to be here with us today. If he comes later, then we will come back to his slides. But until then, I will run through them and we will go to our next speaker. I hope he didn't have some technical difficulty that didn't allow him to be here. NAMA is the National Association of Medication Assisted Treatment, and we have a North Carolina chapter here.
In America, did I help people? It's a medication. It's not a drug. And that's a big misconception. People think that you go there just to get high. And that's not why we're there. We're there because we want to be clean. We want to have a job.
It's the only drug that you cannot get from your doctor, that you cannot get at a pharmacy, that you have to go to a special clinic during special hours and be observed taking it. I don't know anything other than stigmatizing to say about that.
Nobody knew the horrific power imbalance that went on in the average methadone clinic.
It's really difficult to protect yourself from the police abuse, for example, or protect yourself from going to prison.
They don't have any treatment in Afghanistan. They need treatment.
These patients are quite manipulative.
sometimes I know that they have work to do. They have a job, they have a life. And I have to still tell them to come and take treatment here every single day.
This place is run like.
It appears that we have lost audio.
We will be able to achieve a lot more than normal. Our systems of delivering services to people have not shifted along with our understanding.
The method I'm taking is not my identity. Okay, my identity is more. So you want to identify me, label me with a name of a substance that I'm using, you know what I mean? No.
Try the part of Magda.
I'm a drug user activist.
It's nothing greater than living. We all want to live.
The video you just seen is by Helen Redmond called Liquid Handcuffs. And there's a lot in this particular video. And it's very heart touching and heartfelt due to the fact that a lot of us all around the country have heard and seen some of the same things that we have just heard on this video. When we think about liquid handcuffs, having some place to go and can't be able to go because we have to go and sign out. We can't get take homes and things like that. Just having people call you out your name because you're taking a medication and you're trying to make changes in your life. This is the only medication that is regulated like that. I don't have to go every day to a clinic to get my diabetes medication. Why should I have to be under so many regulations just to get a medication that is used for recovery? And it's labeling and stigmatizing. And in the Black and brown communities, is very demoralizing to even have to go through this process due to the stigma behind these said issues. So with that being said, is Helen Redmond here? Or we have another speaker, our next speaker. Aaron Ferguson is going to talk to you about himself. He's the Users Union Leadership Team Leader.
Yeah, hey, this is Aaron Ferguson. I'm with the Urban Survivors Union Leadership Team. And during the day, I work for a national provider of treatments for opioid use. And we're trying to make a difference in the way things are happening in this whole arena. You know, just as Hiawatha was saying, there's a real stigmatizing way that in general, people who use drugs are treated in this country, and that bleeds over into the types of treatment that people who use drugs receive. So really what this movement is about getting rid of that stigma. It's about recognizing the humanity of people, all people, right? There's a lot of conversation going on about that right now, recognizing the equal humanity of all people and practicing equity in their treatment, in their health care and in their medical care. So I'm going to give a quick high-level breakdown of the science that exists around this topic. I'm not going to delve too deep because I want to be conscious of time, and I want to give enough time for the panelist that's after me to talk, because I think it's really important what he's about to say. So really quick, this is how the medication works in the brain. You have 3 different types of meds that are primarily used. Methadone's a full agonist. It's like a bully. It gets in those receptors and takes over the territory. But it also gets rid of the withdrawal symptoms. And the best part of it is it's a long-acting medication. So ideally, if somebody's on a stable dose, they won't feel sick for 24 hours. You know, some of the data shows that 3/4 of people that come to methadone clinics across the country are inadequately dosed. So there's this belief that people are medication seeking when they get on methadone, so we need to keep their dose as low as possible, and that's a big problem. Buprenorphine is a partial agonist. It's become more popular more recently. You know, it's claimed that it has less recreational value. It's less tightly regulated. It most often comes in combination with a drug called naloxone, which is, it's the purpose of it is reversing an overdose, but if it's combined with an opioid, it throws a person into withdrawal. Those are the two main medications that we provide. Naltrexone has become popular more recently, especially with courts and jails, because it's claimed to have absolutely zero recreational value. There are many settings in which it's being presented and provided to people in a coercive manner. The jury is still out on evidence regarding naltrexone, so we're being very cautious with that. Go ahead and skip to the next slide.
Next slide, please.
This is a lot of data here on a piece of paper, but the reason why I picked this particular study out was because it was introducing methadone to just a general population of people who use heroin. And what they found was that it cut the death rate in half. So making methadone available to a population of people who use heroin and other opioids cuts the death rate in half. That's an important thing to remember here. Next slide, please. This next study came out just this last year, and this was doing an important thing, which was comparing these treatments, opioid agonist treatments, to other forms of treatment that are being provided. Now, if you see that arrow way down there at the bottom, what that is what most people get in terms of treatment when they're looking for help for opioid use. They get put in detox, or they get put in an inpatient setting, or they get put in a jail. And what you're looking at here on the y-axis is opioid overdose at 3 months, the probability of continuing without a drug poisoning. And the top arrow is for people on these medications. The bottom arrow is for people in detox and inpatient treatment. So a person's likelihood of succumbing to drug poison is significantly higher with the predominant mode of treatment and the predominant thing that's being done with people who take opioids. That's a problem because there's a major disagreement between what the science says and what we're doing. Skip to the next slide, please. So what did USU do about this? When COVID-19 happened, we started talking about it and saying, man, wouldn't it be great if we could make some recommendations based on what's going on right now about how treatment really should be in the big picture, right? So we came together, and through a process of debate and discussion and dialectic, we came together and decided we were going to write a letter and get people to sign on and see how many people we could get to support these reforms that we were recommending. First step that we recommended was don't discharge anybody. Unless they're coming in and beating somebody up at the clinic, we should not be just kicking people out of treatment. Treatment providers have blood on their hands for kicking people out of treatment because they're continuing to use opioids. You're not going to discharge somebody from a treatment for exhibiting symptoms of their own condition that they're seeking treatment for. And continuing to use is definitely just average behavior for most people when they switch over to these medications. In absolutely no circumstances should we just be kicking people out. Detoxing during COVID-19, strongly discouraged. You're putting people out there in the community when there's a pandemic going on, when there's a lot of dangers out there, and not only are they under the stressors from the pandemic, but you're going to cut them off because of their money. And number 3, we're recommending doing away with the X waiver. There's a waiver that's required by providers and physicians that they have to get in order to treat these conditions. The problem with this is it makes it elective. It says, if you're a doctor who wants to treat people with opioid use disorder, well, you can go and get this waiver and we'll let you treat 30 people for up to a year. And then if you play nice, we'll let you get up to 100. And if you know the secret password, we'll let you do 250. And what happens with this is if you leave it up to doctors to do this on an elective basis, most of them aren't going to do it because stigma is alive and well in this country. And if you give doctors an option, most of them are going to say, we don't want to treat people that take drugs. And so the reason why we're recommending doing away with the X waiver is because we know that it can successfully be done. We know that there's research showing that most physicians already don't want to treat and don't want to get the waiver. And we also know that many other countries have done this successfully, and the fears of diversion that people are citing are outweighed by the benefits and the reduction in mortality. So less people are dying when more people are able to get a hold of these medications, whether or not they're being used as prescribed. Next, we were recommending pharmacy-based delivery, right? So this is a very controversial topic. You know, it would stand to really reorganize the industry as it exists. But we do know that pharmacy-based delivery makes these medications more available to people who would benefit from them. And we're going to have Matthew Bond on to talk about what goes on in Canada here in a little bit with pharmacy-based delivery. Take-home privileges being extended was something that the Substance Abuse and Mental Health Services Administration and the DEA came together and said that they were going to do during COVID-19. They recommended 14 days for semi-stable and 28 days for stable. And in practice, that was completely different. So many providers either did not follow those recommendations. People were crowded into clinics 30 at a time. And the ones who didn't necessarily do it in the most responsible manner. So we want to see things like this being taken into account. Despite all of that, all right, guys, society did not crumble because people got 2 weeks worth of medications, all right? So we want to have a sensible, reasonable conversation about what the evidence says and what science says. The company that I work for, Community Medical Services, is participating in a couple research initiatives to gauge the effect of these extended take-home privileges on people's well-being, on how they are living, and whether or not this has been of a benefit to them. And my guess is that the evidence will demonstrate just that. Number 6, telehealth, right? We need to start doing inductions via telemedicine. We were able to start doing intakes, right? So getting people signed up and hooked up with the buprenorphine via telemedicine. And that was a huge change that took place during COVID. Normally people would have to come to the clinic, be there at 6 a.m., whenever the clinic provider is saying they got to be there. And it's tough for people to get there. When a person decides, okay, I'm going to do this, that means they're going to be sick. That means they're going to be suffering, and it takes a lot of courage to go over and switch from one medication to another. And we want to lower the barriers as much as possible and make these treatments available to people. So we recommended doing away with the in-person requirement for methadone. There was a huge double standard by saying people don't have to come in person to get buprenorphine, but they still have to come in person for methadone. That, to me, the only independent variable there is stigma. So we needed to change that. And we want to have a long-term conversation around how these services are delivered. Can they be delivered in a mobile unit? Can they be delivered by community paramedics? Can they be made more available to the people who can actually benefit from them that may not have the money or the resources or the ability to make it to a clinic? Number 7, we recommended doing away with lockboxes. SAMHSA themselves in tip 43 recommends that this be done with extreme caution because it is a confidentiality issue for a person to be running around with a lockbox. There are sex workers that have found a huge issue with this, from people knowing that they have medications on them. And furthermore, if we're going to put medications in an additional layer of security, we need to do that with all medications. If you can get Coumadin, which is basically rat poison, without it being in a lockbox, all right, you should be able to get methadone without it being in a lockbox. If we're going to put methadone in a lockbox, we should put all other medications that are potentially poisonous in a lockbox. And then finally, we strongly recommend that state and federal Medicaid dollars cover all take-homes. All right. What other medication that cuts the death rate in half or more, thank you, would we be complaining about money about? All right. So if I came out with a medication that cuts the death rate from heart disease in half, would we be arguing about money? Would we be quibbling about whether or not we have the money to save people's lives? No, it's a double standard that's only applied to people who use drugs. So the Urban Survivors Union recommended these steps. We had over 140 organizations sign on, hundreds of individuals, and it drew a line in the sand in the industry between people that are in support of these reforms, that are in the interest of the individuals receiving treatment, and people that are in support of maintaining the status quo. So the reason why we're having this webinar right now is to come together and have a conversation about science, what the evidence says, to support a regulatory system that is based on science, that is based on the evidence. Our country has a big problem with science denial, as we all know. Science has shown us that Black people are equal to white people, that women are equal to men, and that gay people deserve the right to be able to be married. And it's going to show us that people who use drugs are human beings. So that's what this is all about. We're coming together to talk about this. And real quick, I'm going to give you a primer on what my buddy here is about to break down for you. But there's a huge problem in jails and prisons with methadone. In the existing literature, less than 1% of jails and prisons in the country provide these medications. If you're on methadone or buprenorphine and you wind up in a jail, chances are you're going to be cut off cold turkey. The man you're about to hear from, Mike White, has gone in and has had the courage to cold call these jails and to walk in there and convince them. And this guy has convinced more jails and prisons than anybody you'll ever meet to have these medications in their facility. Because you know what? Overdose death rates are 10 to 40 times higher for people getting out of incarcerated settings. All right, 100 times higher than the average citizen. So this is an important conversation. I'm going to cut this off where it's at right now. I'm going to pass the torch to Mike White so you guys can hear about the work that's being done in these settings.
Thanks, Aaron. I'm really not that cool, everybody, but we'll get there. If you can move to the next slide, please. So the reason I am so passionate about this is because I found myself going into a jail on some charges, and after a decade of pretty good use daily, daily use, found myself in withdrawal. And I found myself in withdrawal before, but 24, 48-hour stints and all that good stuff and get released. But this one was I was going to take a vacation for a little bit, so started just having body failure, and I was definitely a person that needed medical help, but I was not deserving of it because I was a junkie or whatever other word you want to associate that with. So I got pissed off and started just asking why do we do these things. So from a historical perspective, it all started off with Rikers Island in New Mexico, kind of just offering maintenance but not induction. So people coming in weren't offered that treatment, but if you came in and were already on treatment, then you were provided that maintenance or that continued support. And so now the big push is induction. You have this great opportunity to do a COWS or a clinical opioid withdrawal scale, see if somebody's struggling with opiates, see if they can be diagnosed with that disorder, and then provide an opportunity to offer them 1 of 3 medications or some kind of service, whether it's residential. I always say, I don't care if it's rubbing 2 chinchillas together that gets you sober, whatever it is, go do it. I don't care what it is. But there's these opportunities that we can put in front of people, like a menu for a restaurant, and whatever they buy into or whatever they associate with or connect with, let's get it to them. But moving forward, these are kind of some of the jails and prisons doing these services. Just to give you a little background, Aaron gave you the guesstimate, kind of. Some people have been doing work like Bloomberg Foundation, some other folks, trying to find out how many people are actually doing MAT. So we've been associated with that just because our clinic probably has the most. And so if you can move on to the next slide, we'll show you what we're doing as a company. Oh, actually, next slide, I'm sorry. Oh, I'm having problems seeing this, sorry. So a couple challenges we have when trying to coordinate with a jail or support. Usually all of these, it's sad to say, we constantly say that our programs are built on the back of a sacrificial lamb. So it's somebody that royally got fucked over about something. They lost their kids, they lost their life, they lost something very big to them, and we got pissed off as a supporter of that person, and we asked why. So we go to the Department of Child Safety or Child Protective Services and say, why are you taking away these children for taking away parents? Or why can't this person continue their medication because they come into jail, and all these other things. So employee culture, corrections officers in general, it's a moral failing still. It's stigma, discrimination. You have correctional and community leadership not aligned. So maybe corrections sees the numbers. They're seeing 500 people coming in a month, but the governor and the political system aren't ready to give it mouth service. They don't want to put their name on it or the stamp on it. So then the jail doesn't feel comfortable doing it, or the mayor doesn't buy into it. So sometimes those parties aren't aligned to look at those things. Pharmaceutical companies, so if they're on the call, whatever, but Alkermes or some of these other folks that are pushing misinformation on the backs of disqualifying other medications or some of these other things, like all that crap needs to just stop. If somebody wants to try Vivitrol, let's give it to them and have them try it. It works for some people, let's do it. But putting it over other medications or trying to make it sound better, I just don't see the effectiveness on it, and so it changes a lot. Third-party healthcare providers. So a lot of jails and prison systems hire a third-party correctional system partner to come in and provide services for them, like medical care services. So sometimes you have to deal with the sheriff, the jail staff, and then the third-party healthcare provider. You have to get them all on the same team. And so maybe it's not in the contract, but then you're renegotiating contracts between the healthcare provider and the jail, and you're not even a part of it. It gets interesting on those things. Concerns over diversion. Definitely you see this with all medications. It's going to happen. Offenders like myself have a lot of time on their hands, and we'll figure out a way to get it, right? So that's just the way we're going to do it. But you can put certain things in line to divert that. So those types of things. Facility and staff resources. So I support some jails that have a staff of like 3. And so they have a moonlight nurse that comes in. I'm talking about Minot, North Dakota, that's popping into my head. So they have a nurse that comes over, you know, once a week and checks on people, but they really don't have the resources. So we got to figure out ways to take care of that for our people when they go in there. And then just overwhelmed at the idea. If you can put yourself in a jail situation, an administrator or a directive in that system, and you want me to do what? Like the best thing I heard was this Montana director, and he had been working in the system for a long time. And he said, you know, for 20 years, y'all been telling me to keep drugs out of my jail. Now you're telling me to bring them in. Like, yeah, we're trying to, something like that. Next slide, please. So these are some of the programs we have going on as a company. So we have most of my projects are all peer support ran. I like peer support run because they make a better connection with people when they're doing inReach. We'll go over inReach here in a second, but I'll just let you read this list. But by this point, we kind of know what we're doing. We can definitely adapt to the system because really we always talk about meeting the patient where they're at. In my job, I need to meet these people where they're at, right? So they have a certain amount of resources. They have their ideological preferences around medication-assisted treatment or around how to treat people in general. So all those kinds of things need to be worked through. Next slide, please. So when we do inReach, we're looking at possible inductions. We're looking at a stabilization period. We got a captive audience. We're really trying to get them set up for release. Put all those missing pieces. Did they need an ID? Did they lose their social security? Did they lose their apartment? Was all their crap in their apartment? So birth certificate, those types of things. We definitely want to get them back on track as fast as possible. Let's move forward because I know I'm struggling with my time here.
You got 3
one more
minutes.
All right, so I'm going to go through these real quick. Whoever's moving the slides for me, I think it's Luis. So we did a Methadone grant, and we're looking at populations inside jails and prisons that were provided MAT upon their incarceration and then following them post. So if you could change the slide. The next slide is just a demographic breakdown. If you can look at it real quick. What's that? Gender breakdown 70 to 30, average age 32.4. Next slide, please. So what we saw was a 36% reduction in arrests, 43% reduction in drug arrests. And again, the sample size was close to 300 people, 266. Next slide, please. We're going to skip this slide for the purpose of time. So this just shows the 30 days. So this is individuals that used for 30 days in a row. So what this is showing is an offset use, so daily use. We said if we go all the way down to heroin, we saw a 44% offset for daily use. Next slide. The next slide is the use in the next 6 months and the offset of those daily days. Or this is 6 months post, I'm sorry. Next slide. And I'll send these out, or anybody who has follow-up questions. What was really interesting about the social determinants of health aspect was we saw a 28% reduction in unemployment and a 71% increase in employment. Next slide. And then we saw a 39% increase in permanent housing. Next slide, please. So there's a couple different models in how to support jails and prisons with MAT. You kind of have the bridge model where maybe the third-party healthcare provider is providing prescriptions for buprenorphine, and then they need a community provider to take over that maintenance script. So we have a project like that There's co-location models like Kodak in Rhode Island, if you want to look at that one, where they're actually sitting inside the DOC and providing those counseling services in MAT. You have the delivery model, which is interesting because we're talking about take homes. So every time I do a delivery model where somebody is, sorry, I'm getting some feedback. A delivery model, we have to do a federal exception. So we have to do daily delivery or bring that person into our clinic until the exception is approved, and then we can provide the delivery. And I see Hiawatha raising his finger. I think I'm over time. I apologize, everybody.
1 minute.
Oh, 1 minute, okay. And then you have the OTP model where the jail is actually their independently licensed OTP. So an example of this is Maricopa County Jail, and then I believe Rikers. And then daily transport model, which is just the offender coming into the clinic. So you see this with a lot of pregnancy projects where the jail doesn't want to support everybody, but they know they're going to get sued for pregnant women. So they support the pregnant women, but then the general population doesn't get anything. And then the future is probably a telehealth model where you can do induction behind the bars. Next slide, if I do have 1 second, because I believe it's a resource. Next slide, sorry. I just want to point out these resources that are kind of playbooks for implementation of medication-assisted treatment. The ones listed are very good. I did want to go over the First Step Act, which is the federal prison, coming out with their announcement that all federal prisons have to have access to MAT. This came through with the First Step project. So this really is going to give us the leverage to those DOCs and local jails. And so this is the first time the federal government has made that announcement. Next slide is a National Council Behavioral Health Playbook. This one's really freaking good if you want to check that out. Next slide, and I think I have one more, but I won't talk on it. I just want to plant seeds to everybody on this call. So this is just a brain dump. You know, we need to look at telehealth. We need to look at Medicaid opening 30 days prior to release. We need to look at medication units for the purpose of co-location. Naloxone upon release, everybody should have naloxone in the property bin. Counseling services, medication efficacy, best return on investment. Maybe an injectable might not be the best return on investment for $1,200 when you can provide 8 people methadone treatment for the same price, and just the other one. So I apologize everybody for going over, but hopefully it was helpful.
Very helpful, Mike. Thank you very much. Thank you very much. There's a lot of information from Aaron and from Mike, and we have to think about the information that was given. And I want people to think about what was said. Sound science. We have people from our own community who have provided sound science, what people have asked for, and still a lot of things haven't been getting done. From what Mike have just showed us, people have gotten stable. People have gotten housing due to the fact of they using the said program that works. Also, to think about the only reason why some places aren't taking into consideration some of the efforts that we're talking about here today is because the drug user is already criminalized, so they don't want to even do anything about that, which is a shame. This country could be the innovators of a lot of programs and a lot of things, but we have other places that are ahead of us. At what point are we going to have our leaders take notice that drug users saving lives, changing lives are valued in the community? Every life matters. Every person is valued. And with that being said, we'll have our next speaker. I'm sorry, next speaker will be Matthew Bond, please.
Hi everyone, my name's Matthew Bond. I am the program coordinator with the Canadian Association of People Who Use Drugs.
Matthew, let me scooch up to your slides. I don't know how we got off track, but let me get to where. Oh, here we go. There we go. Sorry about that.
That's okay. So yeah, change at last. You know, I want to give just to let everybody know what Canada is doing, and every time we present in Canada, we like to acknowledge that the land Kapud works on is the ancestral and unceded territory of the First Peoples of Canada, while Kapud acknowledges that the lands on which we live and work are the lands of the First Peoples of Canada. However, while acknowledging territory is very welcome, it is only a small part of cultivating strong relationships with the First Peoples. Acknowledging territory and First Peoples should be taken place within the larger context of genuine and ongoing work to forge real understanding and to challenge ongoing colonialism. We strive to collaborate and respect all the tribes of Canada and you know, especially the African Canadian population where that has been, you know, oppressed for so long. Next slide, please. A couple of my affiliations, I am the program coordinator with the Canadian Association of People Who Use Drugs. I'm a national board member with the Canadian Students for Sensible Drug Policy, a member of the Halifax Area Network of Drug Using People, and the co-founder of the Halifax Overdose Prevention Society, which implemented Atlantic Canada's first OPS. And I was just recently, I'm a person that has been on methadone for 10 years, on and off methadone for 10 years. I'm prescribed methadone, benzodiazepines, Valium, morphine, and Vyvanse. So I'm on 4 different narcotics, and I get my I get take-home doses weekly, and I have for a long time, long before COVID, and it was really due to the legislation in Canada that allows that, and the real kind of relationship that I made with my doctor. But you know, there is always a way to kind of get safer pharmaceutical drugs if there's political will. And Garth Mullins from the Crackdown podcast just notified me that the British Columbia Association of People on Methadone just recently filed a lawsuit against Mallinckrodt Pharmaceuticals, the BC provincial government, and the College of Pharmacists for implementing methadose without consulting with anybody, and it has really kind of impacted all of Canada in the overdose crisis, and hopefully they will be successful in that lawsuit. Next slide, please. So the COVID-19 response in Canada regarding to opioids, in BC, we've been pushing for a safe supply of drugs for a long time, and not just like a safe supply of methadone and buprenorphine. And I agree with Mike. I'm not a big fan of buprenorphine. Methadone or morphine or hydromorph should be prescribed. So the British Columbia Centre for Substance Use released guidelines to encourage physicians to prescribe a safe supply of not just opioids, but stimulants, benzos, alcohol, and nicotine. And I'll get into that a little bit later. Hotels and community-based organizations have been hosing people experiencing homelessness, which I think that should be a gap that should be filled permanently now. I don't think we should ever go back to the way it was. They have the capacity to do that. And the biggest thing regarding the opioid agonist therapy, I would say, is the Canadian Controlled Drugs and Substance Act granted an exemption to allow pharmacists to renew, refill, and transfer narcotics and other medications, including opioid agonist therapy. And I'll say for firsthand, for like the 4 narcotics that I'm on, I showed up at my pharmacy one day with no prescription, couldn't get a hold of my doctor, and the pharmacist did refill my weekly dose. So these things are implemented. They're only up good until September 30th, but we're hoping the federal government will continue this and maybe make this new legislation. Next slide, please. So this is the exemption here. If you guys have this document, if it's sent out, if you click on any of the pictures, it will link you to it will hyperlink you to the document. But what this exemption really did was allow more patient-centered care for people on opioid agonist therapy or receiving any kind of daily medication, right? Like pharmacists are the ones that you're seeing most of the time in Canada. So in Canada, you get your medication filled at a pharmacy or a clinic, but most times it's pharmacy. So you can see right here, like, and any time if you ever, a safe consumption site or an overdose prevention site, they are legally granted through an exemption to have these sites. So this is a similar kind of exemption. It's with the Controlled Drugs and Substance Act. So it allows pharmacists to extend prescriptions, to transfer to other pharmacies, to permit prescribers to issue verbal orders. So you used to have a signature on your triplicate. You don't need that anymore. and to permit pharmacies' employees to deliver prescriptions of controlled substance to patients' home or other locations where they may be. Next slide, please. So this is kind of the one little spot around the delivery, because I know that's what we're talking about today. So like really anyone that works in a pharmacy can deliver the medication if the pharmacist grants them kind of consent. So they have to, any individual can do it. The pharmacist must deliver the controlled substance or the person to the individual identified in the prescription or to the person responsible of their care. Obtain in a writing or note from the pharmacist identifying the name of the individual affecting the delivery, the name and quantity of the controlled substances to be delivered, and the place of the delivery. I think that is a big one, and going forward, especially with clinics like this should be a thing. You can you know, trust somebody with your medication. If you're not able to access it, we should not be making people go daily when they are, you know, missing a limb or they just have any kind of access issues at all. And also carrying this kind of note with their exemption. So the exemption with them at all times. And I think that's a reasonable request. Next slide, please. So, you know, here in Canada, we've really been fighting for things more than methadone or buprenorphine, because we understand that methadose really does not work, and methadose is a diluted version of methadone, and it has resulted to many lives in the overdose crisis in Canada. So we have been fighting for safer alternatives of drugs. So for opioids, for a safer pharmaceutical supply, you have hydromorphone, morphine, Eslan. You can have a fentanyl patch. There's multiple kind of alternatives for opioids. For stimulants, same thing. It's ADHD medication. These things can be prescribed. I'm sure people in the States have ADHD. So stimulants don't have, they're not as effective with a safer supply program, but at least it provides the individual something, right? So if you can prescribe ADHD meds to kids, you should be able to prescribe them to people who use drugs and who use stimulants. Regulated Valium for benzodiazepines. In Canada, we see a large illicit market of Xanax and alaprazam, just research chemical benzos. And I just want to note that these medications in Canada can be prescribed off-label at any time. We've had doctors prescribing them for 4 or 5 years. So, you know, the sky's not going to fall when people start prescribing drug users drugs. Like, that's the way it should be. We have a lot of people on morphine. We have a few injectable opioid agonist therapy clinics, but they're very limiting, especially in a pandemic situation. You don't want something where you have to go 3 times a day to get it. And the one heroin assisted treatment is kind of that restrictive, but we also have a fentanyl patch program where people go and they get a fentanyl patch every 2 days. They're not allowed to inject it, but still it's, you know, for the case where the methadone doesn't work, it's available. Next slide, please. In some places, sorry. So these are the safe supply, aka risk mitigation guidelines from the BCCSU. Say they're not really using the term safe supply anymore. It probably sounds too sustainable for them. So risk mitigation is the new term, and I don't like it. To me, it sounds like it's going to be taken away as soon as COVID is contained. But this is a great document. Check it out. You know, there's a lot of good work in it. Next slide, please. It really breaks down, you know, who is eligible, what can you give them, you know, and encourage kind of physicians to do so. And this one right here, eligible clients must meet the criteria below. I remember talking to a friend of mine, and one of the reviewers, Garth Mullins and Guy Felatella, Guy told me that, you know, they wanted to put anybody that had COVID-19 as kind of the criteria, and Garth and Guy fighted for no, anybody at the risk of getting COVID-19 is eligible for this kind of patient or this kind of program. And I think that, you know, is probably the biggest win out of all of this, because we are all at risk of contracting COVID-19. Next slide, please. So specifically with opioids, this is what they are, encouraging doctors to do on top of their opioid agonist therapy even, is to prescribe oral hydromorphine 8 milligram tablets, up to 14 tablets a day, or providing MS-Lon and providing that daily. So, this is a huge win for people who use drugs in Canada. They've been fighting for this for a long time. It's a safer pharmaceutical alternative. We would like to see more heroin-assisted treatment programs. We'd like to see heroin produced in Canada, in North America. That would be a huge, solution to our poisoning crisis if we could provide our own heroin and grow it in Canada. But this is a huge win to prescribe Dilaudid for injection drug users, off-label, whenever. Next slide, please. So this is a little bit about kind of delivery support from the BCCSU. Very much is like what the exemption says: deliver directly to the patients, identify the patients prior to the provision of medication, maintain social distancing. But once again, check out this document. I'm sure you guys will get a lot of good information out of it. Next slide. This is the last thing I'll talk about, and I know it's really near and dear to me, but what if we can, reduce kind of daily contact completely for patients who use drugs, so they can go to a non-stigmatizing, non-discriminatory machine to receive their medication daily. Next, please. Next slide. So this is the MySafe machine, and it's in the downtown east side of Vancouver. It's the first of its kind. It's led by Dr. Mark Tyndall and the MySafe Society. The machine is built by Dispension. It has, the population size is only 14 right now, but there is plans for expansion, a pan-Canadian approach. Some of the kind of reasons to use a MySafe machine is, and these are right from the MySafe kind of bulletin, right? You get to access medication, and it doesn't require in-person contact. During pandemic, this is perfect. These machines should be in every pharmacy. They should be kind of like an ATM. You go to an ATM when the bank is closed at night to get some cash out. These should be attached to pharmacies so you can, access your medication whenever you want it. And hopefully we will get there someday. It allows people to get them without any kind of judgment. You don't need any further identification once it has your biometric vein pattern, and your vein pattern is supposed to be more effective than fingerprints and whatnot, and it seems to work great. And it allows, this is the best one, it allows patients to regulate their own drug use. They can go and get it when they want. You can see in real time when the medication is getting dispensed, and the doctor can, increase or decrease, or, kind of have a monitor it, but it still allows that patient to have their autonomy and to regain a little bit back of their life. Next slide, please. I always like to end on this, this slide. It's a great Banksy photo. Keep your coins. I want change. I like to say that harm reduction saved my life, but a safe supply of drugs would have given me a life. I wouldn't have ended up with a criminal record. I wouldn't have overdosed multiple times. I wouldn't have got hepatitis C. So we really got to start looking at this with a patient-centered approach, and getting physicians to ask patients what do they need, what substance is going to keep them from using illicit toxic fentanyl. Thank you.
Thank you very much, Matthew. That was very intriguing, and I love the way you ended that, and I hope everyone else did also, about, especially with it being about change and thinking about the things that he wouldn't have gotten into, and a lot of us are exactly in the same boat in the same way. If only we could reach our politicians and those people that are in power, those decision makers, so that way they could implement some of these sound science approaches that work. Only if they cared about said people within the community, the drug using community, then it would in fact be a big difference. And we have to do better. We definitely have to do a whole lot better, with this. There's so much more that I could say in reference to these points, but I'm gonna keep us moving along. And our next presenter will be Dr. David Frank. Oh, and before Dr. David Frank comes on, I'd like to remind people that what I didn't do during the introduction is one thing, that there's two parts to this. This is the first part, and then there is a second part. And then in the second part is going to be led by Ms. Dana Ortiz, okay? So, and like I said, if you have any questions, please ask your questions. Allow us to answer the questions. If we don't have the answers for those said questions, we'll respond to them via email, but we're going to try to get to questions in the question and answer period. Okay, Dr. Frank?
Okay, I've got a note from Dr. Frank that says he's muted. Did you go on from your presenter link that I sent you? So you should have gotten a presenter link, and that wouldn't have muted you.
Whoever's the organizer can unmute him.
Oh no, that means it's me. Oh no. All right, I will give it a try. Let's see if attendees. All right, I'm gonna do my best here. Oh my gosh.
All right, not a problem. In this new age of working from home.
It might be.
I see it. I got the list right here. I gotta find him in the list. All right. So
in
just
this new
bear
age
with.
of working at home, let's bear with the technical difficulties, and we're still gonna have a good presentation.
So it looks like it's in alphabetical order.
I'm unmuted. Can you hear me?
Yeah, we can.
Yes.
We're rolling.
He's unmuted. Yeah, he's muted now.
Okay.
Excellent.
Throat. Okay. Hi, everybody. I'm glad to be on. My name is David Frank. I am a sociologist who studies opioid use, opioid treatment, and particularly methadone maintenance treatment. I'm currently a postdoctoral research fellow at New York University's Behavioral Science Training in Drug Use Research Program. That's a mouthful. Importantly, I am also a drug user who's been on methadone maintenance treatment for about, oh, wait, my slides are moving. Okay, you could, oh, it's fine. That slide's okay too. As I was saying, I'm also a drug user who's been in methadone maintenance for more than 15 years. And one of the goals of my scholarship has always been to amplify the voices and lived experiences of actual people that use drugs. It's probably not a big surprise to any of us that there's been a lack of that in terms of scholarship. And I think that has a lot to do with why so many of the theories that they use to explain us often feel really distant and removed from our actual lives. So I wanted to talk about my work, particularly my recent efforts to reframe methadone maintenance treatment within the larger context of criminalization and the war on drugs. So this is the right slide. Now we're right on the right place. So why do people that use illegal opioids go into methadone maintenance treatment, and how do they benefit from doing so? So the way that methadone maintenance treatment is generally conceptualized is through concepts like addiction and recovery. So according to this view, people who use illegal drugs, quote unquote addicts, experience problems because of their disease, addiction. Similarly, they're seen to engage with treatment as a response to their disease, addiction. The problem with this view is that it's all about the individual. It doesn't include any of the larger structural forces that we know play a huge role in people's experience, and particularly the kinds of harms that they experience using drugs. Things like race, class, and the one that I focus mostly on is legality. So whether the drug you're using is legal or illegal. I started thinking about this stuff because I was never really satisfied with the way that drug use was explained, either when I was an active drug user, which I guess I still am, but especially once I got onto methadone maintenance treatment. I got on methadone maintenance not because I wanted treatment per se, certainly not because I wanted to become abstinent or to pursue recovery or anything like that. I think like most people, I got on methadone maintenance because I was exhausted of the hustle and the risk and getting arrested and getting ripped off and, you know, every single day. All things linked to the illegality of heroin. In fact, I was fine when I had drugs, particularly if I had them for a length of time, which was not that often. It was a problem when I didn't have drugs. So one day, it sort of clicked that there was a methadone clinic in my neighborhood, and I realized, hey, I could give this clinic $50 for the week and get my opioids there instead of going through the hassle of the street. And it ended up being more than just a week. I've been on 15 years now, and it worked wonderfully. But I want to point out that it didn't work because I became abstinent. I'm not abstinent. It didn't work because I became a different person or because I had any self-transformation. It worked because it decriminalized my opioid use. And so next slide, please. So treatment as a response to or refuge from policy. So eventually I went to graduate school and ended up pursuing this topic for my doctoral dissertation. I did a 2-year interview and ethnographic study that examined how this narrative that we use to understand methadone maintenance, this addiction recovery thing, how well did it actually align with the experiences of people on methadone maintenance? The answer is not that well. First of all, there's tremendous diversity amongst people on methadone maintenance treatment in the way that they conceptualize their drugs, their drug use, in what they want out of treatment. So there isn't one singular narrative that explains people on methadone. But perhaps even more importantly, the majority of people that I spoke to were using methadone for the same kinds of pragmatic reasons that I was. It wasn't because they had some internal desire to become drug-free or to change or to be a better person. It was because of external pressures associated with heroin's illegality and the fact that that made it impossible for them to live their lives. Lots of people told me just directly, oh, I would much rather have been able to stay on heroin, but I know that that's impossible. Other people just framed the reasons for pursuing methadone in the same way that I framed them. They're sick of the hustle. They're sick of getting arrested. They want to have a job. They'd like to go to school. They don't want to spend every day, you know, with this. And again, all of which is linked to the illegality. Next slide, please. Okay, so some people might say, well, what's the big deal? So clinics don't really understand all the ways that they're helping their patients. I would argue that it is because that methadone maintenance is framed in this way that it is so punitive and so paternalistic. It is characterized as being about turning quote unquote bad and sick people into quote unquote good and healthy people. It's not framed as being a refuge for people from an unfair, oppressive, state violence filled system. And that is in the way, that's the actual way it's helping a lot of people, but it's not framed that way. Not surprisingly, methadone maintenance is really unpopular, particularly in the United States. We have very low rates of use and retention. And that's a problem because, as most of you probably know, methadone does a lot of great things. It lowers your rates of overdose. It lowers your rates of transmission of bloodborne viruses, lowers your rates of recidivism, all kinds of great things. So if a significant portion of the patient population isn't taking advantage of it because it's not speaking to them, then that's an issue. Next slide, please. Thank you. Oh, I lost the color on that one. Okay, so reframing methadone maintenance treatment. So yeah, I would like to reframe methadone maintenance treatment to include, one, just that there's diversity of people's treatment goals. We don't need to hit everyone with this abstinence-based recovery addiction kind of narrative. People conceptualize their drug use and treatment goals differently. Secondly, I think we need to start acknowledging that lots of the patient population is using and benefiting from methadone maintenance because it's a refuge from harms created by criminalization, not necessarily just because of addiction. Next slide. Oh, that changed up my slide a lot. Okay. So potential effects on policy, some actual real world changes that I would like to see. The biggie is legalization and regulation of illegal substances. That's at the top of my list. However, it's probably not coming anytime soon. So I would be happy to see office-based physician-managed care like we do with buprenorphine, or low-threshold clinics and a greater use of harm reduction in methadone maintenance. A lot of times you hear methadone maintenance described as harm reduction. I don't think that it is, certainly not as it's currently administered. It's an abstinence-based system. If they make people come every day, unless you're clean, quote unquote, clean of all drugs, that's abstinence. That's not harm reduction. Okay, next slide. I think this is pretty much my last content slide. Okay, so changes related to COVID-19. Obviously, there's been a lot of bad stuff that happened with COVID, particularly to marginalized populations like people that use drugs. However, there's also, as some people have talked about, there's been this weird opportunity in that they have liberalized the take-home guidelines. In that lots of people who used to have to come every day now could come once a week, once every 2 weeks, although it has been, as noted, unevenly administered. Nevertheless, the people that are getting it for able to stay home now are a big surprise, happier, more stable, like their treatment better. And I just want to point out that myself, other academics, other advocates, other people on methadone, we're out there now collecting this data so that we can present it to the policymakers and say, look, we don't have to be so heavy-handed with this. And we can, actually let people have their methadone. I want to thank you all very much. The next slide, I think, just says thank you. And I want to thank the Urban Survivors Union for inviting me to speak. Thank you very much and be safe.
Hi,
Dr. Frank, thank you very, yes.
I just got a message from Joycelyn. She's going to fill in for Zach. So I'm going to go back to the first slides about NAMA.
Okay, excellent. Excellent. Thank you very much for that info. So our next speaker will be Joyce from NIAM, National Academy of Medical Assisted Treatment, and we'd like to thank her for joining us and presenting her slides today. I hope everybody's enjoying the webinar thus far. It is very informative and it has a lot of information, and I hope something can come out of this where we as a community can come together and systematically create changes that are better for the whole community.
Joycelyn, can you talk? Are you muted? I don't hear you. She says she's muted. Nina, could you help me get her unmuted?
So we're gonna get her unmuted. We're sorry for the operating difficulties, but please stand by, stand with us. And in this time of COVID, everybody is going virtual. So we wanna be patient and ensure that we get this done so we can hear everyone.
Thank you so much. Joycelyn, you should be able to talk now.
Okay, all right. Where am I? Okay, can you hear me?
Yes.
Yes.
All right, so anyhow, the primary objective of NAMA, it's the National Alliance of Methadone Assisted Recovery, is to advocate for the patient in treatment by destigmatizing and empowering MAT patients. And first and foremost, NAMA recovery confronts the negative stereotypes that impact on self-esteem and self-worth of many methadone and buprenorphine patients with a powerful affirmation of pride and unity. Change. Next slide. Okay, the 5 goals. They're missing. Okay, you got to click on them. Okay, to eliminate discrimination towards MAT patients, to create a more positive image about MAT, to help preserve patients' dignity and their rights, to make treatment available on demand to everyone who needs it, and to empower MAT patients with a strong public voice And if you don't agree with that, then you're not an advocate for patients. And very easy to agree with them, you know. Okay, this is another one that I think you have to click on.
Yep.
I mean, I can get my thing
Can you
out.
not see it? It's in, they're there, it's just in white.
Yeah, I know. Okay, let me see what I have, because I'm not sure this is the 5 goals, right? Or no,
This is what
what is
NAMA accomplished.
Okay, we missed something, but the federal regulations. We successfully advocated for monthly methadone take-homes 1 week. It was 1 week maximum before the current federal regulations, although New York had, of course, prior to medical maintenance, they had also what was called aftercare, which was 2 weeks take-home. We advocated for the prohibition of dose capping and blind dosing. So that was actually written into the regs. And the other piece that's missing on this is we insisted that there be some way that patients have input into the policy of their clinic. And when the regulations were first changed, that was actually done quite a bit, and it's just kind of dropped off because it's the accreditation bodies who are responsible for doing this, and they don't tell programs, hey, you got no way of patient input here. We have advocated for best practices. We helped raise the average dose from, it was 35 milligrams to over 60 I think it's up in the 70s now. We positively influenced state regulations where somebody from NAMA existed. We bought or joined lawsuits on behalf of MAT patients and advocated to be awarded legal standing on behalf of MAT patients or prospective patients with the passage and signing of the ADA. And let me go to the next page. You can change it, but because there's two of what is NAMA accomplished. We created and continue to oversee the Certified MAT Advocate Training course. It must be over 1,000 people now trained to be MAT advocates. From what was originally a New York City specific focus in 1988 when we started, NAMA Recovery organized a national organization, and actually they organized us. I have to say that. To respond to the needs of methadone and buprenorphine patients. For the last 30 years, we've inspired methadone and buprenorphine patients in other countries to advocate and create organizations. And we developed, of course, the first federally funded peer-to-peer recovery support program to the needs of methadone and buprenorphine patients. And okay, and that's the Mars project. And unfortunately, we just lost our funding this past April. So I don't know.
Wow.
I don't know. I'm hoping that we can jump on the COVID thing and maybe get some money, because a lot of people being locked up and having to stay home all this time, depression, anxiety, people with anxiety disorders, that's easily 1/3 of the patients. Anybody having any kind of trouble. I know patients have lost their jobs. So, you know, they were the first ones to lose their jobs. So we're going to have to figure out that. And we have developed, which this is like 35 years, no, not 35, it's 25 years. We started it in the mid-90s, a patient grievance complement report program so patients can connect with an advocate and have a guidance and support and tell them what to do, because methadone is very confusing. Very often, most staff don't understand it. Now, where are we? Okay, what's next? All right, we're at the end. We need to start reorganizing again. We lost a lot of our chapters when we were really focused on Mars. We have about 35 Mars programs or projects operating in the US and in Vietnam. So, we were focused on that for a while because we don't get funding. Advocacy does not get funding, unfortunately. You've got to have a service to get funded. So now we need to focus on state chapter affiliation and guidance so that patients, and especially in states where there are a lot of patients, and an intentional collaboration. What's that? I can't read this. Collaboration, and collaborate with other advocacy organizations. And that's another emphasis. So that's it. So if you want to get involved, you can go to www.methadone.org and //advocate list HTML. There's a link from our homepage to that, and fill that out. And we have a group that we do every week. And right now, what we're focusing on is targeting the states that are very prohibitive, I guess you'd say. The ones that, you can't, like Pennsylvania, you can't get more than a week, and it takes like 5 years to get that. And a couple of other states are that bad too. And then there are some programs that are also that bad. Now that's going to be harder, but they are there. And first you start with the states where you'll have the largest impact. So that's what we're, in these next 2 weeks, that's what we're doing. And that's it.
Beautiful. Thank you very much for your input. That was very informative. I'm sorry to hear about losing the funding to the Mars program. Here in New York, it appears to be working. There's a lot of people that were involved in that particular program. With that being said, ladies and gentlemen, that was part 1. We're going to move on to part 2. And part 2 is going to be safety, stigma, and research. And the facilitator for that is going to be Ms. Dinah Ortiz.
And right before Dinah Ortiz comes on, I just want to say, Zach and I had talked about this webinar when it was planned. And one of the things I know he wanted to say, and he couldn't be here today, was just that we're 2 organizations doing 2 very different things, but we want to come together when it comes to medication-assisted treatment. It's too important for small differesences to separate us. So while we have Urban Survivors Union that's here as the user union, representing people who use drugs, and NAMA representing people on medication-assisted treatment, these are both groups you can get involved with. If one doesn't resonate with you, then try the other one. But the important thing is to be involved. Dinah?
Louise, let me say something. We have also got the fight of the century coming up in the next year, and they're trying to take away our confidentiality in methadone treatment, and actually in any licensed federal program. And they already took pieces away from it. They just snuck one in the stimulus bill, that now once your information from a methadone program goes to a hospital, you'll never get it back, and it can go all over the place. So, and it'll be there for life, because we have electronic records. Years ago, when it was paper, every 7 years they'd dump it. But with electronic funding, once it gets in there, it's in there for life. So this is the fight of the century right now. People won't come into treatment because of it,
That's right.
you know, and I know people that want to leave treatment because of it. So anyhow, that's what we all have to keep an eye on the next year.
Well, thank you so much. My name is Dinah Ortiz, for those of you who don't know me. I am part of the USU leadership team. And before I pass it over to the amazing panelists that we have here, I wanted to tell you a little bit about my story with methadone, or shall I say my struggle. It's been some time since I've been on methadone. I'm non-bupe. I made the decision to switch over because I was starting a new job where I would be representing the whole of the Bronx community. And in all of my shame and internal bias, all I could think about was repping a client who I had just seen in the clinic that morning.
Dinah?
I made the decision, yeah, so that's why I made the decision to switch over to Butte, because I knew that I was going to be representing Bronx and I would be running into clients. I all I could think about was running into a client that I was going to go do a home visit at the end of the day. This was before I this was 10 years ago, so this was before I had all the experience that I have now and had yet to gain all of the knowledge I have now about MATs. If I didn't show up right at 6 a.m., I was sure to be on a line wrapped around the corner. And either I was going to run into a client or I was going to be late for work. Every time I went to dose, there was an issue. I couldn't get dosed because I hadn't met with my counselor in over a week, or my Medicaid was cut off and I needed to recertify. The staff didn't care that I was about to be late to work or that I had a life outside of the clinic. They knew they could hold me. They knew they could hold me hostage as long as it took. Holding that little plastic cup with orange liquid in it over my head like a carrot until whatever situation it was for the day was resolved. Eventually, I ran into clients and would come up with excuses as to why I was there. And I'd say things like just checking in on a client, or I'm escorting a client to get dosed, etc. I was mortified each time. Nothing ever went swiftly. And God forbid I needed to speak to the manager of the clinic, who would always arrive no earlier than 1 p.m. My day was shot. As I sat on the filthy chairs they had in the waiting area, hoping my name was called next, I would reflect on how many people in the program were experiencing the very same thing as me. Some of them mothers with small children and no childcare, so they would have to ask a stranger to watch their children outside while they sorted out their issues. People who had to be at work at 6 a.m., so they were always late to work because they needed to dose. There were just so many different issues to mention in one presentation. But what I will leave you with is this. I decided to switch over to buprenorphine and have never had to stand on a line wrapped around the corner again to get my script. And that's how it should be with methadone. There needs to be immediate changes. There's no time to wait. We have to keep in the forefront of our minds at all time that people are dying for some of the reasons that I've stated above. So let's unite now and act. And I'm going to go ahead and pass the baton on over to, I believe, Matthew Bond.
Mark Kinsley.
Oh, Mark Kinsley, sorry. Mark Kinsley, and Mark Kinsley is going to talk to us about overdose training. Mark, go ahead.
Thanks, Anna. And I'll make this fairly brief. I think a lot of people have probably done quite a bit around the overdose stuff since we've been inundated with it over the last couple of years. But I just want to touch base and give some information on this that might be valuable to people. First and foremost, I'm really proud of being a part of the Urban Survivors Union's leadership team. 2 weeks ago, we had the opportunity to send medication to Ohio, to a place in Ohio that did not have access to the medication. And so the medication that we sent there has already rescued over 11 people. And so it's an amazing thing. We're going to do very quickly, recognize, respond, evaluate, and then we'll tell you how to get the medication. So we'll do the recognize first.
Hi, this is Dana Saltzmanachia from Texas Drug User Health Alliance and also with Urban Survivors Union. I want to thank everybody for giving us the opportunity to do this today. I'm excited to be a part of this. And I'm going to start with recognizing an overdose. So if we were to say come up to someone, we're driving by, come up to someone on a bus stop, some of the things we're going to look for is, possibly like a loss of consciousness, maybe someone looking like they're, sleeping or not fully, fully awake, unresponsive to outside stimuli, unable to talk, breathing is shallow. It's sometimes referred to as the death gurgle. It's like a really shallow breath, kind of like a raspy sound with it. Bluish or ashen complexion, someone like losing color, lips turning blue, fingernails turning blue, body is excessively limp or rigid, pulse is slow, erratic, or not present. You're going to want to look to see someone possibly may already not be breathing. The pupils are pinned. So what you're going to want to look for is, first of all, with the loss of consciousness, checking to see if someone is, maybe just in a nod or if they're actually unconscious. I'm going to pass the mic to Mark, though, and he's going to teach us how to respond once we recognize the symptoms of overdose.
So very quickly. So when you come up upon someone like that, the best thing to do is, yell their name, hopefully, or just, try to startle them. If there's no response to that, what you want to do is you want to start what we call a sternal rub. You're going to take your knuckles and you're going to go in the chest bone and you're going to rub really hard. If they respond to that, they're not an overdose. If they don't, you need to act quickly. So at this point, you want to try to call 911 if you're someone that would do that. But either way, the next thing you want to do is administer the Narcan, and then after you administer the Narcan, you're going to want to start to do rescue breathing. If you don't have Narcan, just to let you know that you can keep someone alive long enough to EMS gets there just by doing rescue breathing. So rescue breathing is easy to do, but it's not easy to keep up for a long period of time. So after you call 911 or administer the Narcan, you want to take this individual, if you can get them on their back, that's best. You want to tilt their chin up, open up the airway gently. You want to see if there's anything in their mouth obstructing the airway. Remove it if it's possible. And then you're going to want to take your opposite hand. You're going to want to pinch their nose and then go down and put your mouth over their mouth, encapsulating it. Give 2 very, very strong breaths, and then 1 breath every 5 seconds. So once you do that, you repeat doing it. And if that individual doesn't come to after the administering the Narcan and the rescue breathing, you want to wait about 2 minutes to 3 minutes and administer another dose. Usually people will come out of it by then. So if you don't know, there's a couple of things. There's intramuscular naloxone, that's injectable, and then the nasal. So either way, if you need this medication, we'll put a phone number up there. It's 860-724-5339. And if you need the medication has been donated by the Levinson Foundation, and so we will ship it out to you. So we just wanted to do a real quick and dirty overdose presentation. And then what we'll do is if you go on, there's a link that actually has a overdose training. So with that, Dinah.
Thanks, Mark. Actually, that's really interesting. I was not aware that you could, there were these special things that you could do until EMT showed up, especially for people that get really anxious and really nervous when they're witnessing an overdose, and there's no Narcan around. Those are really good steps that they can take now, that they know of until EMT comes so that they can save that life. So I really appreciate that.
Yeah, it's really important to let people know that you can actually keep someone alive by breathing for them if you don't have Narcan available.
Yeah, that's really good information. Thank you for that. And next is Liz Day, and she's going to be talking about methadone in children.
Can y'all hear me?
Yep.
Thank you, Dinah. Hey, everybody. My name is Liz, and I am with MCSU. I work at the Greensboro Exchange with participants, and I'm also our hepatitis C educator and peer navigator. I've been a patient at the Methadone Clinic for the last 5 years, and I've had many different experiences there. Some of them have been good, but some of them have been bad. And I will say at this time in my life, I consider myself to be in self-defined recovery. So unfortunately, the clinic doesn't always do their part to educate patients. And for those of us that are also parents of young children, the stakes are even higher because, God forbid, if an accident does end up happening, we would be the sole party that would be held responsible. And it can be sad, it can be frustrating that a place that can offer such a salvation can also turn into a nightmare because of all of the hoops that they make you jump through. And that can make it really, really difficult on families, especially families with children. So in the beginning of me going to the clinic when she was younger, my daughter, who is 8 now, really resented the clinic because at that point in my life, I was still using every day, like very chaotic. My life was just crazy. And so all she saw was me leaving to go to the clinic every day, but then I would go out and do whatever else I needed to do. But all she saw was that took me away from her. I've been a patient at the clinic since 2015. I started on bupe, and methadone is what I'm on now, and that's really what ended up working for me personally. It took until last year, though, for me to eventually get into enough legal trouble and get the opportunity to do drug court that really forced me into abstinence. So just in that respect, the clinic has been a godsend. And over time, my family has started to see that it was really helping me get better. So now that my daughter is a little bit older, I really wanted to explain a little more, you know, other than just like, don't touch this box or, you know, don't take mommy's medicine. I really wanted to take some time and make sure that she understood a little more about methadone and what could happen if she were to take some of it. So although she's not 100% on exactly what it's for, I don't know that she really cares, honestly. But I've tried really hard to not hide it from her as she's gotten older. And she knows that my medicine is in the big white lockbox. Honestly, at this point, I'm glad that she's not old enough to want to get high yet and take it. And I feel like it's a really good thing that right now she thinks that it's gross because one day she was beside me whenever I took my dose for that day and she thought that it smelled disgusting. She was like, I'm never going to take that. And so I was like, good, don't. You know, she's not really into taking medicine at all, even, you know, medicine for when she's sick. She just wants to play Minecraft and watch Dan TDM videos. But another thing for me personally that also allows for a level of separation is that when I finally did get my shit together, my mom, who had been raising her, won't let her come to the clinic with me because she doesn't want her sweet little baby around those people. But we all know stigma, parents being extra, that's a whole other story. One thing that the clinic never really did was give me any kind of like in-depth education about children and methadone, other than, oh, well, don't let your kids around it, don't let them take it, they'll die, keep it in a lockbox. So I really wanted to make sure that I had it covered, because if something happens, it's my fault, right? So I've had the talk with my daughter, but also with my parents, since we live with them right now. Was it awkward? Yes. But was it necessary? Also, yes. I really feel like it's time that we start picking up this slack where the clinic leaves off. I don't know about y'all, but I love to keep getting 13 take homes after COVID is over and done with, whenever that is. So let's please make sure we all have naloxone in the house, and make sure everyone who stays there knows how to use it. I use this really cute video to help me explain about what an overdose looks like and how to do a reversal with naloxone. It's called Bunny and Wolf, and my daughter really liked it. It's really cute, and we will have the link for y'all for anybody who does have kids and wants to use this video to help you talk to your children about it. Feel free. It really helped me. I definitely did do this little presentation of the video and talk with her away from my parents because of how my mom is. But I did have a separate talk with them too. And even though they weren't exactly thrilled about it, they know how to use the Narcan too. It's kept in our first aid kit along with the other emergency medications and stuff, because I feel like that's where it belongs. I personally believe that Narcan should be given out along with any opioid prescription, but we're not quite there yet. I also plan to revisit this with my family as my daughter grows older and change things about our safety plan as necessary. I encourage y'all to make a safety plan with your children and families, because it's never a bad thing to take responsibility for our actions, our recovery, and those we love and care about. We'll have a link to the Wolf and Bunny video, and you're welcome to use it if you want to. Thanks so much. I really appreciate being a part of this.
Thanks, Liz. That is so. That really struck a chord with me, because when I was on methadone, my kids were younger, and so there really were no conversations, and I don't think up until this day there are no conversations from your counselor that you meet, from all the people all the staff members that you interact with in the methadone clinic, about talking to children about methadone, except for keep it away from them, right? And I think it's important, and I had always been transparent with my children throughout my drug use, and so they knew because of my transparency, but it wasn't anything that I was, guided through by the clinic. So I think that it's really, really important that they do something about that, that they help parents, mothers, or single dads or single moms or whatever, talk to their children about the importance, one, of needing to take methadone, but also why they should they should stay away from it and they should not be touching it. So thank you for bringing that up. We really appreciate it.
Thank you.
Next is Sharon Larson, and Sharon is going to speak to us about methadone and pregnancy.
We may need to unmute her. Sharon?
I can't unmute, so.
Okay, hold on. I'm going to see. Sharon. Let me see. Let me see. She was definitely here. Sharon, write in the chat box if you're here and muted. If you just let me know if that's what's happening. And I've spoken up a few times, but it appears I was not heard. Okay. Sharon Larson. Okay, so I have her right here.
Sorry, I don't see her as an attendee.
Yes?
I'll see if I can unmute her. Let me see.
Could you do it, please? Thank you guys for bearing with us. Sorry about the technical difficulties.
Can you hear me, Louise?
Yes, I can.
I do not see her as an attendee.
You do not see her. She
I
was
am trying.
She was here. Rhea, do you want to?
Yeah, let's move on to Rhea and give Sharon some time to come back on if she's going to come back on. Rhea's going to be talking about pregnancy.
Yeah, she's not on here.
Okay, well, Rhea, do you want to go ahead?
Rhea's muted.
All right, could you unmute Rhea?
Yeah, if I find her. I don't see Rhea either.
Yeah, I see her.
You see her?
I see her. I'm staring dead at her.
Okay, she was definitely here.
Yeah, so she's muted.
Okay, Nina?
Let's see, I'm looking for the editor, the staff.
Can you hear me?
Yep, here she is. She's unmuted. She's good.
Hi. Okay. Hi, everybody. My name is Rhea Sinas. I am co-founder of the Academy of Perinatal Harm Reduction, which is an advocacy organization and also an organization that works to educate clinicians, parents, and frontline service providers about substance use disorders during the perinatal period. I was also recently awarded a Comer grant with USU to start up the mail order syringe access program for pregnant and parenting people who use drugs specifically. I'm also a person with lived experience, and as a result of medical malpractice and stigma, I was forced to deliver my child by emergency C-section at 25 weeks. Which, if you're not familiar with what that is, that's 3 months premature. She weighed 1 pound when she was born. So I'm here just to talk about, as drug users and people that work on the front line, all of first I'd like to say thank you for allowing me to be here, but all the things you all were talking about today, they hold so much more weight for pregnant people who use drugs. Imagine that you're a person who is opioid dependent and you can't access services because even amongst the drug using community, there's so much stigma and marginalization. People that work in syringe access programs don't even know about what the gold standard is for pregnant people who are using drugs, and that is medication-assisted treatment. There are currently 23 states that consider it fetal assault or child abuse if you're using drugs while you're pregnant. So that not only are you stigmatized and marginalized for being a pregnant person or a person who uses drugs, but you have no bodily autonomy. And that is even worse for women of color. And so access to treatment is always an issue for lots of people, especially people in rural communities. And with COVID-19, it presents a whole nother series of issues because pregnant women are given guidelines, pregnant people are given guidelines to stay at home. So being able to access and having take homes is like a huge deal. There's been a lot of data and evidence provided to folks today, and I just kind of wanted to speak to the fact that we need to do better around educating ourselves as drug users and as people who are providing services on how to use appropriate language, how to support and become more inclusive and normalize the fact that people that use drugs also have sex and get pregnant. And most of the time, no one ever says, gee, I'm going to start shooting heroin and get strung out when I'm fucking 3 months pregnant. Like, that doesn't happen. And so we need to do better in terms of just providing and accessing services, because what we know, just for the average person, is that people that are on a stable dose end up living meaningful lives, and that's the same with pregnant people and families, and also providing services for partners too. So I was kind of told to keep it short and brief, but if you're interested in training your own staff or learning more about how to get involved in supporting pregnant folks, or how your syringe exchange can get involved and become a partner with us, with WoodWorks, please feel free to reach out to me. I don't have a slide or anything that shows my email address or anything, but
I will put it up at the end, Rhea. That is my fault. So I'm so sorry. That
it's fine. It's actually my fault, because technology and me don't do well. And now my kid is freaking out, so I have to go. But thank you so much for giving me the opportunity to be here, and I hope to continue the conversation with you guys in the future. So thanks so much.
Thanks so much, Rhea. Really appreciate it. We're going to go ahead and move on. We have Sarah Brothers, and she's going to be talking about research in methadone. Sarah?
Yeah, I'm here. Thanks, China. And Louise, slide, please.
Yeah.
So my name's Sarah Brothers. I'm a member of the Urban Affiliation, and I'm just going to talk for just a few minutes about a short survey for methadone patients that we're conducting. The survey is super short. It should take less than 5 minutes to complete. We left a comment box at the end of the survey for anything else that you want to share with us. So please write as much as you'd like. We're going to be collecting responses for the next month. So we're hoping to get at least 800 responses. So please share the link to the survey. Hopefully you can find it in the chat box with your friends and with people at your clinics. So, as we know, our COVID-19 demand letter, it's been covered in a lot of media outlets. And they've said what we know, that methadone patients, they're at risk during the pandemic. In-person clinic visits put people at risk. And while some clinics are expanding take-homes, some are not, right? So as one Vice News article that covered the letter wrote, even in a national emergency, clinics can opt in or out of the new federal protocols. And so it's falling on patients to advocate for their rights to dose at home, but that's a lot to ask for individual patients. And there's a lot of reasons why that would be hard or impossible for some people. And of course, we'd really like patients to have more control over what risk they're exposed to and more choices about how they protect themselves from risk. And we also think it's important to ask you these questions, not the clinics. People rarely ask patients about their experiences. And for patients, this can really be a life or death issue. So in hopes of making some changes in how methadone is dispensed, working towards expanding take-homes now, and working towards making some of these changes permanent, we want to get at what some of the risks of exposure to COVID-19 are for methadone patients, and we want to get at people's risks by state. So we're trying to collect this information so that we have some support in numbers and some ideas about what areas of the country are making the fewest changes. And this information could really help support our arguments for some of the changes that we think are so important. Louise, slide, please. So we're asking in this survey what is happening across the nation regarding some of the issues that we raised in the letter. Have take-home privileges been expanded, and if so, how? What is the financial burden on patients? What are some risks for patients when traveling to the clinics and inside the clinics? Have toxicology tests been suspended? And has telehealth replaced in-person requirements? And finally,
what is going on in the clinics. What are some of the ways in which clinic policies might be making it difficult for patients to practice social distancing inside the clinics? So this is information we can collect and we can use it to work for change, and then we can distribute it to let people know this is a problem and also get some idea of how much of a problem this is. Slide, please. So this survey, it's anonymous, and I feel that's important. So this information isn't going to be linked back to anyone, and any potentially identifying characteristics, they're going to be removed before any of the information gets shared with even a few people. So I wanted to walk you through the survey because it's really short, and quickly show what we're getting at with these questions, what we're asking and why we're asking them. So first, there's just a little bit on demographics, age, race, ethnicity, gender identity, and these are going to tell us whether there are differences. For instance, if women are getting more or less take-homes than men, if changes in clinic practices are different for some ethnic or racial groups, if younger people are getting tested more often. Basically, we'll see if there's some groups that are at more risk and see if the changes that have been made may be biased against some groups of people. Louise, slide, please. And then I'm going to ask you really quickly to just go to the next slide. So this one we just have a couple questions about health insurance and how much you might be spending per month on methadone. And that's to get at how much risk people are at of not being able to afford to keep taking methadone. And then state and city to get at how far you travel, how you travel. These questions are important. It allows us to see what areas are and are not making changes to take homes, what areas are most risky for methadone patients, an idea of how many patients are at risk just from traveling to the clinic, like say if you have to take public transportation every day. And also on this slide and in this section of the survey, we're asking how long you've been prescribed methadone, and we're asking this to get some information on how new patients may be at more risk or at different risk than patients that have been prescribed longer. Slide, please. The next slide is going to show the basic information on how clinic exposure has changed. Like how often did you go to the clinic before? How often now? How many take-homes did you get before? How many do you get now? And adding this information to the other questions in the survey, that's going to allow us to see how take-homes and clinic visits differ by state, city, gender identity, and a bunch of other variables. Louise, slide, please. We also want to collect a little information on how people are getting counseling services now. And this is to see if one of our demands is still a problem for people, and that's replacement of in-person requirements with telehealth. So we hope to learn how often did you go to the clinic for in-person counseling services before, how often do you have to go now, and we hope to get some idea of whether people are still getting support if they want it, and if they're getting it in a way that doesn't put them at risk. Slide, please, Louise. Next, one of the demands of the letter was that drug testing requirements should be suspended. So we'd like to know if this has happened or if drug testing requirements have decreased, and then for what groups of people and in what areas. Louise, the next slide, please. And then social distancing. We're just looking for a brief idea of if and how your clinic may be trying to reduce your risk during in-person visits. And we put write all you like comment box in there if you'd like to give us any details. Like, are people still required to line up? Are they required to line up outside? Are they limiting the number of people inside? Are they doing curbside pickup? And then finally, in the last box on the survey, there's a question, is there anything else you'd like to tell us about your clinic practices during COVID-19? And we would just love it if you'd share with us anything that's on your mind, both good and bad experiences, just anything about your experiences with your clinic in the last few months that you'd like other people to know. And we're going to share these results with you. So please look forward to seeing a report from USU on the information you shared about your experiences soon. If you have any questions, please email us at methadone@ncsunion.org. And thank you very much.
Thank you, Sarah. That was really, really helpful and useful. And I look forward to seeing all of that information. Are we putting that up in one place? Are we going to have all of this up in Basecamp? Do we know? Or
Yes, the survey is at the link right there at the https://forms.gle right there. So, and we also have the survey attached to the to the webinar, and we will send the survey out to everyone after the webinar. And we ask that you please take it.
Perfect, perfect. Thank you so much, Louise. And last but not least, we have the wonderful Katie Simon and Nick, and they're going to talk about methadone story and stories.
Yeah, hi. I'm Katie Simon. I'm a USU leadership team member, and I'm a methadone patient of almost 15 years. A quote unquote bad one. The pandemic is the first time I've gotten take homes. Another hat I wear is editor and writer at Tits and Sass, a long-running media site by and for sex workers, which has been quoted and linked by the New York Times, the New Yorker, the Washington Post, etc. So as a writer and editor, stories are very important to me, but they're vital for all of us. As leadership team member Louise always says, a story is more powerful than a fact. We can spit all this beautiful, meticulously researched data all day, but no one will truly understand until they hear our stories. That's why culture projects are so important to USU and our chapter, North Carolina Survivors Union, just as important as any other form of advocacy or activism. We've done story sharing and story crafting around being women who use drugs or are in the sex trade, around Hep C, and now around methadone. I'm going to say a few things about why we tell stories as methadone patients, and then I'm going to give it to Nick to take away. So methadone patients tell different stories for different reasons. They're the stories we're forced to tell to survive, to keep our methadone and keep going. And you know those stories. You've heard people tell them in mandated clinic groups. You've heard yourself tell them to your counselor, to nurses, to so many people. Those stories go like, I'm so glad they took my take homes. I was going down a bad path. When we tell that story, we don't talk about the jobs we lost having to daily dose again and completely change our schedules, how we might have lost our take homes for arbitrary reasons, like losing a lockbox or not being reachable just that once for a call-in. We're even taught to tell stories where we blame other methadone patients around us for the bad things that happened to them. Oh, he was using. He deserved to get terminated from the clinic and have his risk of overdose go way, way up. This methadone is a privilege. They tell us these stories and have us telling them as if we're all children, some good children and some who misbehave so badly we deserve to die. They have us telling these stories to divide us, instead of having us remember we're all one class of patients who can stand up collectively for our rights. Then there are the stories we tell each other. You've heard these stories too, in long lines of methadone patients, frustrated, tired of being yelled at and called junkies by the security guard. When we tell stories just between us, we talk about things like our anger at bureaucratic clinic systems ready to rapidly detox us on a dime if we lose our insurance or stop being able to pay up front. Clinics who made us dose in person during COVID-19 in overcrowded waiting rooms till the last possible moment. We're not supposed to tell these stories or even think them. As drug users, we're supposed to take accountability and moral inventory and blame ourselves for everything, even the systems that hurt us. Because if we thought for ourselves, we might start to wonder why so many clinics are kicking people off for not being abstinent when methadone dosing provides better outcomes for people even if they are using. We might start to think about all the regulations forcing us into mandated, insurance-billed counseling and groups, taking up our time and making it harder for us to keep jobs, when studies have shown that these sessions and groups don't affect outcomes either way. We might start to question the very nature of the clinic system, a system perpetuating itself on endless staffing and supervision and bureaucracy and insurance money, when so many other countries handle methadone dosing matter-of-factly in a streamlined way, mostly through pharmacies. What we're trying to do is tell stories to heal ourselves, tell stories where we're free to talk about the entire truth, not just that one lie about the bad, careless, selfish drug user who didn't deserve the privilege of methadone. And now I'm going to let Nick take it away to his beautifully crafted methadone story. Nick?
You may need to be unmuted.
Let me see if I can do it. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, Nick. I don't think I can do it. Can Nina, you or Louise do it?
Nina must be able to do it. I can't get to all the audience.
Oh, I can make him a presenter. Maybe that.
Make him a presenter.
I did, but he's still muted.
All right, let me see. Nina, are you there?
Oh, wait. He unmuted himself for a second. Nick, do what you just did again. There you go. Oh,
Yeah.
no.
Yes, I
All
am.
right, can you hear me, guys?
Yeah.
All right, my name is Nick Moyles, and
that was me.
thank you, Kate. Can everybody hear me? My name is
Yes.
Nick Moyles, and I work at the Indiana Recovery Alliance at an SSB, and I do work with viral hepatitis and methadone reform and a million other things at the union, which is where I'm happiest. So I'm gonna read you my story. Nick, wake up, my wife screamed for the 1000th time, her normally calm speaking voice edging into anger. The rubber band in her hair signified her readiness for combat. It was almost 7 a.m., and in order for our mighty red Civic to get to Indianapolis, an hour and 15 minutes away, we had to leave early. The clinic was notorious for arbitrarily closing their doors right at 10:30 a.m. for an hour and a half. I got up, I washed my hands and face, got dressed. I almost made it to the front door, but I forgot I needed the bank-tight security lock bag containing my 27 empty take-home bottles. That all-important blue nylon bag that held my bottles of joy. The clinic was so far away, and I'd forgotten that bag enough times, only to have to drive all the way back. That lesson had finally sunk in. My wife grabbed the keys, and we got our coffee and hopped in the car for our monthly ride up to the clinic. I had been at this clinic on and off since I was 18. It had been my 40th birthday last week. I'd been to at least 15 counselors, 4 directors, and about 100 nurses. More people had handled my urine than I can count. Urine, that vital fluid, the end-all be-all of MAT patients' fate. I'd gotten a couple false positives in the past and racked up large bills proving that they were false. I was going on 10 years during this stretch of being in the clinic. I was full of confidence because I knew I wasn't using, and I knew I had all my bottles with the right dates on them, and I knew that I was okay. I walked up to the 10-person line formed outside, which was small considering the line sometimes stretched in a meandering crisscross of the large parking lot. I checked my cracked screen phone and breathed a sigh of relief that it was only 9:25 a.m. As I passed through the crowd barriers and up to the nurse station, I realized this was not a nurse I knew well. Her panda-covered scrub top was crisp and new. This is always a moment of dread for me, for any clinic patient. Will she be kind? Will she be mean? Will she want my pee? I decided to go with the patented institutional personality number 1, courteous and polite, since that is my effective go-to at clinics. I handed her all my bottles and watched as she counted them. She set them in front of her, and everything seemed to be going fine. Then her beady eyes turned to something one could only see from her vantage point. "This lid is not right," she exclaimed. All joy fled at her weirdly gleeful exclamation. I told her that the lid had to be right because the clinic nurse had given it to me. "We'll see about that," she said. I was petrified. How could years of work be jeopardized by a person so eager to dole out punishment? Her squared shoulders and the hands on her hips told me right away that this was going to be a long fight. After a lot of back and forth, this nurse still insisted that the bottle lid was wrong. I was sent to my counselor to talk about my bottle lid problem. I explained to my ex-pastor counselor that I had seen the lid, and it was an old lid of the type that the clinic had been using a couple months ago. He put out his smooth hands to me and started a prayer. His generic ministrations felt like a frickin' death knell. Damn it, I thought, I am fucked. The battle waged for weeks with me on daily dosing and the clinic going through the motions. I took pictures of that exact type of lid in a labeled box lids at the clinic office. I provided endless proof of my good record. Nothing seemed to matter. Eventually, we had a big meeting with the director and the State Opioid Treatment Authority, the SOTA. The SOTA was a tower of a man with a bevy of gold rings that would shame of him. He had an easy manner born from his own personal struggles. We shared a lot of the same life experience dealing with what drug use brings. The soda was on my side and stated that the state was even okay with giving me back my take homes. I was being backed by authority. This was a new experience for me. Yet the clinic director, acting on all the wisdom she accumulated in her 28 years on this earth and her 3 years in the MAT business, said she could not prove that it wasn't diversion, so she took my bottles away. The soda was blown away, and it showed as he wringed his hands. The triumphant clinic director offered me a week of take-homes instead of taking all 28. This was a courtesy, they said. I told her that there was a very special place for people like her. The soda actually sat there the whole meeting and stuck up for me, exclaiming that the state would go to bat for me at the federal level if needed. But in the end, the clinic won. The soda still tried in vain to comfort me and offered a lot of good-hearted suggestions, but I was absolutely done. I'd resisted the temptation to raise my dose as high as I could go. I was actually slowly tapering my dose on my own accord. I'd even bought into the idea that higher dose meant I was trying to get high. God, I could have used an introduction to you guys in harm reduction right then. I had been in a great place in my life. I had just bought a house, got my kid through 20 surgeries, and married the most amazing human I had ever met. I was trying to get off SSI and look for work. This clinic fiasco was one of the most debilitating things that had ever happened to me. In the end, I went back to cadging quack doctors for methadone pain prescriptions. I would rather trust the lies I tell them than the lies the clinic tells me. For me, being in the union is probably one of the most powerful things that's ever happened. Being able to be collaborated, having the whole idea that I'm not alone, the love they give me and the support has empowered me to actually do this when I felt I was alone for most of my life. Thank you, guys.
Thank you so much, Katie and Nick. That was a wonderful story. Really appreciate it. And now it's time for questions. Do we have any questions from anybody?
Yes. So I have to pull this back up. Hold on 1 second. I don't know how to get my,
And I want anybody to feel free to answer the question once Louise asks, because it's coming from the community. So if you have the answer, please feel free to go ahead and answer it.
I think people are muted. I'm trying to get my, my screen back up. I don't know where my screen went. So
I'm
sorry.
Xing out the present.
Okay, so we have a number of questions, and I tried to go through and answer some of them. A lot of it was just comments and questions about could we link things. I don't see, most of it is just, if anybody has a question, they can raise their hand and we can let you talk. We're gonna close out soon just because we're past 7 o'clock and we don't wanna hold you hostage too much longer.
Yeah, I got a question. It's Garth in Vancouver.
Yeah, great.
Hey, how's it going? Great presentation, everybody. Been on methadone for about 18 years. I got a text from someone in this meeting saying, hey, you're lucky in Canada, you guys have all this stuff. And, you know, I just wanted to say for all of our comrades across the US, you know, we got racist, murdering, violent police forces up here too. We started our own drug war in like 1908. And so any of the reforms that we've got that people might think about, we got from fighting. You know, we got from organizing. And I'm with a group called the BC Association of People on Methadone. You have to be on methadone or drug use to be in the group. And we're always thinking about bigger strategic alliances across North America so that we can overturn all our stupid local rules and punishments and the things that are putting us in the gun sites. So I just wanted to, I guess, just throw it open to anybody who jumps in there and has like thoughts about organizing, because we're facing similar parallel for you all at the end of COVID, them wanting to take back reforms that they'd given to us. And so I'm thinking about that fight coming up and just wanted to hear people's thoughts.
Well, they're still on Zoom.
Thanks.
Thank you. Can everybody mute their line that's not talking? Because I can hear a couple of you talking in the background. And thank you so much. This is Louise with Urban Survivors Union. And I just want to say, you know, organizing is, you know, that's why we're here today. That's what all this is about. And Urban Survivors Union is working really hard and has been working really hard for the last few years. Well, really longer than that, but we've been working in a different way for the last few years to grow and to really come together and make some change. And I think this is exactly the kind of thing we need. We have a Tuesday night organizing call every Tuesday night. I put my email address in the chat box, so we have two. Louise@ncsunion.org, and you can get in touch with me and I can let you know when all the meetings are. I'm going to send them out to everybody that was on the call. We're going to send you our, or everybody that was on the webinar, you'll get a list of all of our resources and ways to be in touch with us. But we absolutely are dead set. We want to organize with everybody around the globe that wants to do something to end the drug war and end this end all of this nightmare.
I'll just piggyback off of Louise. I think, you know, COVID, we have a prime opportunity where, you know, a lot of us with criminal records can't travel back and forth across the borders, but that doesn't mean we can't organize and fight against the system. And that is one thing that we should be fighting against. Most of us can't travel freely because of this racist drug war. You know, so that could be one specific kind of item action, along with the safe supply of drugs and access to methadone, a sustainable access to all kind of pharmaceuticals. But I think, you know, we really need a North American drug user union.
Right. This is Helen Redmond. I'd like to just, I wasn't able to talk earlier after the trailer was shown. The trailer is much better than what you saw. It was just, it's a problem with the presentation, but I wanted to let everybody know, and Mari Lena, my co-director, is with me. We want you to know that you can use our documentary to help organize the struggle to fundamentally transform the methadone clinic system. We are hoping to get a grant, and so we can come to your city and you know, we'll have the funds to help, you know, rent a space, you know, pay for what is necessary to screen the documentary, because we very much made it in the spirit of activists on the ground, people with lived experience, being able to take this documentary and watch it and discuss and debate, and then also to take it to policymakers to show them there is another way to deliver methadone. And I just want to add, because in the United States, we're talking a hell of a lot about policing right now. And for us, methadone is policed. It is policed from the minute you get in that line, you get in the door, you're policed when you wait to get your dose from the nurse. Counselors are policing you. Your urine is policed, right? Surveillance, observation. It is a mini police state. That's how I think about methadone clinics. I get no pleasure in saying that, by the way. So that is what we're talking about. We're talking about a system of control and coercion and oppression of people on methadone. And we very much want to end that system. The clinic system embodies stigma. And as long as you have a clinic system, that stigma will be there. Now, I want to just make it clear, I'm not saying all staff that work in methadone clinics are like this, but the system forces you to do things. It forces you to police. And as long as we have that clinic system, that is the way it's going to be by and large. And so at the end of our documentary, we make the case for closing methadone clinics and moving to a pharmacy-based system. And I'll just end there. Thank you. Get in touch with us. You can go to our website. I'll put it in there. You can go to the Liquid Handcuffs website and request a screening. We have a form for people to fill out. And we want to go everywhere with this film because we want fundamental change.
And Helen, thank you so much. And I'm sorry about that. I'm sorry. We had such chaos in the beginning, so I'm really sorry we didn't get a chance to do that right. But I will send out your information with all the other information to all the attendees.
Thank you. Thank you, everyone.
Hey, this is Nina with North Carolina Survivors Union and the Urban Survivors Union. And I just wanted to show you guys some t-shirts we have available. We have a store online. They're all about supporting methadone reform. If I can share my screen for a second, and then we'll send out that store link with all the other information for you guys.
I just want to remind folks real quick that also keep in mind that there's naloxone available. There's lock boxes available. So reach out to the people that you need to reach out to for the said lock boxes and naloxone that they are making available for us. And let's keep in mind that we can do something to keep change and to make change with the Urban Survivors Union and the great work that they're doing.
Thank you so much. Yes. So yes, the telephone number you can call to get free naloxone and free lock boxes, 336-669-5543. 336-669-5543.
All right, can you guys all see my screen?
Yep.
Yep. All right. So these are cool shirts that we have. We have this one, the Free the Methadone, the cup and the chain. It comes in black and pink. We've also got our Free the Methadone group, a little sciencey shirt. Oops. That one also is black and pink. Oh, sorry, that one's black and white. And then the last one we have is our favorite, our Mr. Methadone, like the Mr. Softy. Nick helped create this one. It's one of our favorites. It comes on a white or a black shirt as well. And on the back of all the shirts, we've got the USU logo. That's what, when you think of methadone reform, I want you to think of Urban Survivors Union, because we are leaders in methadone reform. And all come in small, medium, and large, $30 each. And then there is a store site that I'll share with you as well. It's posted up on our Facebook page, the link to the store site through Square.
Thank you so much.
It's taken so long though. Let's see this.
Robert, are you still here?
Right.
Yes, I am.
Yeah, I'll just leave it there. Yeah.
You want to close this out, Robert?
Yes, sure thing. So I want to say to everyone who presented, Matthew, Ina, everyone, Liz, thank you so much for sharing your stories and presenting. I want to give a special thanks to Hiawatha Collins for facilitating. This has been an awesome webinar. And I just want to remind everybody during this time of COVID, during this time that we're going through the issues that we're facing in the United States, which has now become a global issue, keep in mind that we are all one people, and we have a unique opportunity right now to fight and to win, right? Let's all stay the course, right? Nothing we do alone can be solved. Everything we do together is more than just possible. So from all of us at USU and NCSU, I'm Robert Suarez, thanking you for your time this time. Until the next time, stay safe and wash your hands. Peace, everybody.
Thank you.
Bye. Thank you, everyone.
Thanks, Robert.
Thanks, Robert.
Thanks, everyone, for having me.
Take care, everyone. Be well.
Oh, one last
Thank
thing.
you, Matt.
I'm sorry, guys. One last thing. Please remember, this Tuesday,
Oh,
at
yes.
9 o'clock, we will be holding our national USU organizing call. The link, Nina, if you can really quickly, can you put that link up for Tuesday so that people can see it and just grab it really quick? On that call, we have a very special guest presenting, and that individual will be Cassandra Frederic. All are welcome. It's going to be a really dynamic call. You don't want to miss this one. Please share widely with your groups, and I look forward to seeing you all there. Once again, thank you for your time this time. Till next time. Love you. Peace.
Thank you.
Thank you. Thank you, everyone.
Love you, Robert.
See you on Tuesday.
Take care,
Much
everyone.
love, support.
Thanks, everybody. Have a good night.
Can you throw in the chat when the next meeting is?
Next meeting, yeah, I can absolutely do that. Tuesday
Thank you
night,
so much.
Tuesday night, 9 p.m. Got me.
Yes, I
And everyone that's still on here that
I
can
got
see,
that.
you will receive with your, everybody receives an email after they've come to the webinar, and so you'll receive some information in the packet that thanks you for coming to the webinar. And we also just want to say thank you for bearing with our technology issues, and just, we are not, we're not technology experts. We're people with lived experience, so we come to you with our stories, and that's what we've got. So thank you so much, and thanks everybody who shared from their heart. I really appreciate it. Methadone has been one of those things that has been a struggle in my life, and so finally having some people talk about reform really gives me a lot of hope.
Yeah, well, thank you so much for your transparency and your vulnerability.
Right.
So much love to you guys. Thank you.
Thank you.
See you soon. Bye-bye.
Can you guys see this? Can you see the link, Robert?
Yep, I can see it.
And I put it in the chat box.
Yeah.
Good.
All right. Good.
Thank you, guys.
Okay, cool.
Thank you, Robert. I really appreciate it.
All
And
right.
if
I'll call
everybody-
y'all. Love y'all.
everybody that presented on the call, you should be expecting a call from me in the next few minutes. The union has a gift, so.
All right. Love you guys. Bye.
And anybody that wants a recording of the webinar, it will be available in a few minutes.